So, welcome for this new session of live webinar during the obesity course. And today the topic will be discussing about Roux-en-Y gastric bypass and single loop gastric bypass. I think it's an interesting question to know which of this operation we can perform and in which cases. And so I may introduce the faculty. Peter Angelos coming from the US, Almino Cardozo Ramos coming from Brazil, Jean-Marc Chevalier coming from Paris, Bruno Dillemans will join us a little bit later, Manuel Galvao Neto from Brazil, Kelvin Higa will join us a little bit after also, Jack Impens from Belgium, Leon Katz from New York, from the US, Alphonse Pomme coming from the US but was born in Canada, and Michel Sutter coming from Switzerland, and I hope that Liz Wenstrom will join us also. So a very short introduction for the key points for Roux-en-Y gastric bypass and single loop. For the Roux-en-Y gastric bypass we have a small pouch. We have a biliary limb that measures up to 30 to 75 centimeters. We have an alimentary limb that is 100 to 150 centimeters. We have one gastrojejunostomy, we have one jejunojejunostomy, and we have also two mesenteric defects that we can close or not. We can discuss about this. It's behind the jejunojejunostomy and behind the alimentary limb when she crosses the transverse colon. Looking for the single loop gastric bypass, we have a long narrow pouch. Biliary limb is longer, 200 centimeters, making an omega loop. There's just one anastomosis, is the gastrojejunostomy. And the first question that I would ask to the experts is, do you think that sleeve single loop gastric bypass is easier than Roux-en-Y gastric bypass? Is that a shorter operative time? What do you think about these technical considerations? Jack?
Oh, it's here. Okay, I'm sorry. I think it's an easier procedure for two reasons. The first one is that there's only one anastomosis, and the second one is that, at least in my practice, Roux-en-Y gastric bypass is only performed in people who have a hiatal hernia and reflux. So I do need to do a full hiatal dissection when I do Roux-en-Y gastric bypass. So that's two major differences between the two techniques, at least in my practice.
Okay. Yes?
Well, there is only one anastomosis, and in the Roux-en-Y, the enteroenterostomy has its own morbidity. We all had some dilatation of the excluded stomach due to a kinking of the enteroenterostomy, and that's why we decided to evaluate this operation after the prospective randomized trial showed that it's shorter with less complication and the same results at 1 and 2 years.
Almino,
I'm not sure if it is so easier. Maybe that if we look for the point of view of technique, maybe easier, but it's not safer. I think that we have a lot of literature comparing both procedures, and we have more complications in omega loop gastric bypass than in Roux-en-Y gastric bypass, and I think that we have to discuss more deeply the situation.
I think it's an easier technique. I think the one problem that I see with this operation is if you have a leak at the anastomosis, it becomes a lot more complicated. Given the fact that you have an easy access to a gastric remnant, which is excluded in the gastric bypass, but if you have a leak at an omega loop, there's really no place to control the enteral feeding and then drain the anastomosis at the same time. So you have bile and gastric secretions or buccal secretions. So I think that's an issue. It has an interesting history in the United States because the results were maybe not what was published on the results, the actual results, and there was a significant amount of of complications from the operation, but I think in the last 5 to 10 years, it has really taken off around the world and is definitely a procedure, given its technical simplicity, which has a lot of proponents.
Silvana, you want? No? Michel?
Well, it's probably easier because you have only one anastomosis, but it's certainly more difficult to make a long, narrow gastric pouch starting you stapling below the Krauss food than doing a small pouch upwards. About the long-term results, I think it's a different issue, but technically, I'm not so sure it's so difficult, and the jejunostomy is certainly a very easy part of the Roux-en-Y gastric bypass.
Another technical consideration, because you have a very long loop and you have a very big Peterson space in the single loop gastric bypass. It's shorter in the Roux-en-Y gastric bypass. Do you think we have to close that openings or not? And what are you doing?
Well, until now we have done more than 1,500 mini bypass, and we until now did not have any internal hernia. So we do not close the Peterson space. I would say, as 30 years ago, we didn't close it when we did a gastrojejunostomy for ulcer disease.
Yeah.
I must say
Your micro.
I must say I always close the Peterson's defect. Don't forget that the first internal hernia was described with a loop gastroenterostomy by Peterson in the early 1900s. And there's also reports now in the literature of actually internal hernias. And in my practice, I did encounter it. And one of the cases was with a very significant necrosis of small bowel.
Whenever we have this discussion on internal hernias, I often wonder if the hernia is able to be closed completely, why not close it? So instead of asking yourself why close it, you might ask yourself why not close it? Does it really take that much longer? We saw a good example today. It took less than 5 minutes. Yes, it is a large space, but hernias can occur in large spaces. We did gastric bypass and did it for several thousand cases before we finally realized that, yes, it was important to close the Petersons, even in the anticolic gastric bypass. So I think the real question is why not close it, and I'll leave it at that.
More than that, in the last 2 years, we have at least 2 reports in the literature talking about the occurrence of internal hernias after the omega loop gastric bypass. And basically in the literature that we have in the Roux-en-Y gastric bypass, one of the issues that increase the number of hernias is the longest we do the alimentary limb and the biliopancreatic limb. So as we are working with long limbs, I think that we have to close, we must close, and there are reports in the literature talking about internal hernias after the omega loop gastric bypass.
I totally agree. We need to close all the defects now. There's a randomized trial from Sweden showing clearly that you have fewer obstructions and fewer internal hernias after Roux-en-Y if you close. I have no personal experience with the omega loop, but there's no reason why there wouldn't be any hernia in this space. I think there are 2 questions: why not to close and how to close. I personally prefer closing with running non-absorbable sutures, which have proved to be the most effective in the long term.
And when you don't close and you have an internal hernia, that can be totally terrible for the patient. And we had all cases that came and we had to remove a long part of small bowel and making some stomia and so on, but in some patients. And it's one of the reasons why we prefer also to close all the cases. We changed the technique also with the threads, because at the beginning we had non-absorbable thread, it's proline. And even with proline, we came back and we saw that the reopening of that closure, it's not a reopening, it's just the fat that disappears and the hole is reappearing. And today we're using another non-absorbable thread that gives more inflammatory reaction, and so we have better results and less reopening of. And on the other hand, it's sometimes very difficult also to make the diagnosis of the incarceration of some bile, especially on the biliary limb. So the next question is about the complications, specifically to the single loop gastric bypass. About anastomotic ulcers, we spoke about the internal hernias, and if you have some other ideas of complications. You want to begin?
Well, yes, we had a 3.5% rate of reoperation after mini bypass, and I think the most important concern is marginal ulcers that can happen in more than 2% of the cases, and in three cases it was perforated ulcer that happened 2 or 3 years after the mini bypass. But it was also always patients that had that were heavy smokers and no longer took their PPI medication. So I would say, well, of course, eradicate Helicobacter before, give PPI, stop smoking if possible, and if you cannot stop smoking, then go on with PPI afterwards. It's the principal problems. We did not have such a concern with biliary reflux because we had only to reoperate 14 cases. That's less than 1% of the cases because of intractable biliary reflux. And it's a very special part of the population because these 14 cases had intractable reflux 2 years after, when they had lost all their excess weight, which is completely different from the heartburn that can happen after the operation. And those, they suffered each night, so it was necessary to convert it into Roux-en-Y. But it's less than 1%.
Well, theoretically, there should be many more anastomotic ulcers after mini bypass or omega loop, for 2 reasons. The first one is that the pouch is much longer, and we know from the literature, at least for Roux-en-Y gastric bypass, that the longer the pouch, the more anastomotic ulcers we have. Also, we have the fluid that crosses the anastomosis is bile plus gastric juice, etc. So it's much more ulcerogenic than what we have with the Roux-en-Y gastric bypass. But then reality or clinical experience shows us that it's not the case. So I think that it's probably an issue that we can better address after mini bypass with PPIs than in case of a Roux-en-Y gastric bypass, because it addresses the acid issue. And I'm not sure that with Roux-en-Y gastric bypass, marginal ulcers is caused by an acid condition.
I think people underestimate very significantly the number of ulcers you see if you do long-term follow-up in gastric bypass patients. It may be that they do smoke, it may be that they take non-steroidal inflammatories, or it may just be part of the operation. But marginal ulcers occur at least in 2 to 4% in the literature, but probably the clinical experience is actually much higher than that. And I would venture that about 25% of my patients, 20 to 25% of my patients are on long-term PPIs because they've had either ulcers that have been documented on endoscopy or symptoms of heartburn. So it's not an operation completely without heartburn, and I understand that Dr. Suter is going to bring up the point that there's not that much documentation of reflux, but it's not necessarily acid reflux in gastric bypass. I'm not being a proponent for one operation or the other. I'm just saying, to say that mini gastric bypass creates more ulcers than gastric bypass, perhaps we underestimate just a little bit how much there is ulcer disease in gastric bypass patients.
Hello.
So that's interesting. As an outsider, because my role in surgery now is training, observe you, what you do. So I see very interesting things. Jean-Marc, first thing, careful with this, and Jax, careful with the silent bioreflux. There's nothing in our body more aggressive to the esophageal mucosa than bile. So, and you're right, you go both right. Maybe you have almost the same reflux forever, but any reflux of bile can cause trouble. And other thing is you cannot expect the patient's sensibility to guide you. So with a surgery like of that design, my recommendation, I think Silvana's recommendation as endoscopists and physiologists, is check your esophagus. It is, and the other thing I see is, and it comes from our previous experience on mini gastric bypass, I don't see the literature of mini gastric bypass addressing dyspeptic symptoms. And what we could evaluate in our own group when we're doing mini gastric and Roux-en-Y, that the group of Roux-en-Y gastric bypass have a better quality of life in terms of those symptoms. And we could clearly see, at least in our group, that, and it's coming from Manuela, the information, that those patients take more medicine for symptoms. So that's something that I never see on the literature. Other thing that drives my attention as an observer is to dig in the literature. So if you see the prospective randomized trials, and most of them were designed for the one who perform mini gastric bypass, they are biased. The construction of those randomized trials, they were built to prove superiority. And I don't think we should fight. Mini gastric bypass is an awesome operation, but going to be better? No. Try to go on non-superiority, and you're going to be fine. And what we see that the ones who do gastric bypass, I'm not talking about you both guys, we acknowledge all the complications that it and damage that it can give the patient. I don't see that kind of responsibility in people that are the announcers of mini gastric bypass. That said, again, both are very nice procedures. Just the behavior of the ones who are performing and publishing that is something that, as an observer, you're trying to be neutral, because I don't have any side, is what I see.
I'm not an announcer of mini bypass. I am a public surgeon working in a university that tries to evaluate this operation. What I can agree with you is that we don't have long-term results with this operation, but we didn't have also with the sleeve gastrectomy. And the first long-term results that are arriving now at 10 years show sometimes that there is Barrett's ulcer in 14 cases after sleeve gastrectomy, which means that the reflux is a concern in the sleeve gastrectomy also. So, of course, we need to have long-term results. We began studying this operation in 2006. So next year we will have 10 years results of the mini bypass, and we'll do, of course, the endoscopy and exactly the same work as that's been done by Gerhard Prager in Vienna. And I'm sure we won't have 14% of cases of Barrett's ulcer. Let's see. But we'll study it, and if there is any problem, I'll tell you. That's my job.
I think that this observation that Manuel did is very important, because in the patients we did mini gastric bypass, we could see that the patients are not complaining, but if we do an endoscopy, we can have bile inside the esophagus in at least 50% of these patients. Another issue is that all of we agree that we have more ulcer in this operation. So if we have more ulcer, we have more bleeding, we have more stricture, we have more pain in the patients, we have more compromising the quality of life. And I'm not sure if this is adequate to compare these procedures exactly with a Roux-en-Y gastric bypass, as the nature of this procedure is much more malabsorptive. Maybe we have to compare this with duodenal switch or biliopancreatic diversion.
I partly agree with you, but I must say that if you limit your indications for mini bypass to patients who have a continent lower esophageal sphincter, I don't see why they should have more bowel esophagitis than the regular population. Also, don't forget that the fluid that gets into the stomach after mini bypass is exactly the same that the one that gets into the stomach after, in 80% of the cases after a laparoscopic cholecystectomy. Don't forget, 80% of patients after laparoscopic cholecystectomy do reflux from the duodenum inside the stomach. So there's actually, I don't think, any difference into what gets into the stomach between those two groups. So again, I really think that if, at least in my practice, that's been our experience, if we limit the indications to patients that have no signs of reflux preoperatively, I don't see why this bowel story in the esophagus should be an issue.
What's about cancer and anastomotic liner and the cardia in the single loop or in the Roux-en-Y gastric bypass? But yeah.
Well, interestingly, I just have a patient now who developed a cancer on the anastomosis, but on the gastric side of the anastomosis after a Roux-en-Y gastric bypass. And was a patient 2 years out after the procedure. She had biopsies preoperatively that showed no intestinal metaplasia or anything. She was HP negative, and still, after 2 years, she came to the office complaining about new onset dysphagia. She got an endoscopy and she had a cancer. So, I mean, if this had happened in a omega loop gastric bypass patient, it would have been in all the newspapers.
So this is the 50th anniversary of the gastric bypass. Of course, like many 50-year-old, it's had some other modifications over time. And there's less than 25 cases of gastric cancer, in most of them actually in the excluded remnant, and very few. I reviewed this recently for SAGES, and most of the cancers were found fairly late because they occur in the remnant. So I wonder what we're going to be saying 50 years after we do the omega loop gastric with the exposure to bile. And we'll see. Again, you can't call, I think, Jacques, I'm going to agree with you 100%. I think if you do this operation, it's another indication that preoperatively endoscopy is very important. It's important to do that in sleeve gastrectomies, and I wonder if those people that had the 14% Barrett's, if they've had, you know, endoscopy before and showing whether or not they've had hiatal hernias or not. And I think it's important to do that in gastric bypass patients who are being considered either for a single anastomosis gastric bypass or the mini bypass, which you have to figure out a name. Omega, single anastomosis, mini, or the Roux-en-Y gastric bypass. And I think it's important to figure out, because it'll help you decide which kind of surgery you offer a patient, although we had a very good example today that upper or preoperative endoscopy and even upper GI series don't always tell you the whole truth.
If I can add something, we tried to have quick information on this problem of cancer. That's why we did experimental studies on rats. And we had now prolonged exposition of rats to mini bypass and theoretical biliary reflux. A rat can live 2 years, so we kept them 16 weeks, which is equivalent to 16 years in human. And we had histological results, and now we have also the markers. And so we see that there is hyperplasia, foveolar hyperplasia at the level of the gastrojejunal anastomosis, but which doesn't come up to the cardia. And we measured the markers of the Barrett's ulcer, the carcinogenic markers of the Barrett's ulcer, and also the carcinogenic markers of the gastrointestinal cancer, and we saw that there is no difference after 16 weeks in rats between sham rats and those who had mini bypass. So it's the first information, but it's the first time prolonged exposition has been studied in rats, and will of course go on there.
If we look for the history of the Roux-en-Y gastric bypass that started actually as a Bureau 2 gastric bypass, we see that we learned something with the history of the procedure. One is that with the Roux-en-Y gastric bypass, we can avoid biliary reflux. And the second, that we have to decrease the size of the pouch in order to avoid complications as ulcer and other complications. So it's interesting because now when we compare both procedures, we are in the other way in this thinking. Also, regarding the discussion about the name that Alphonse did a point, it's interesting because, in my opinion, this mini gastric is not appropriate because really this is a maxi operation. That's not a mini, it's maxi. More effect that the Roux-en-Y gastric bypass is more powerful, is more metabolic. So I think that the discussion of the name is another very interesting discussion.
May I say something? I don't think, I mean, I agree with you, but the problem is that the term mini gastric bypass is the one that patients use. And when you look at the internet, people talk about the mini gastric bypass, not about single anastomosis or whatever. They can't even pronounce it. And so I think it's important to, to respect the choice of the public. And why not use a mini gastric bypass? Mini gastric bypass has nothing to do with the effects, it has to do with the approach. It was used the first time because they used it with a mini laparotomy. That's where the term comes from, mini gastric bypass. So why not just keep it?
Because it's very misleading to both patients, doctors, and everybody.
You can't change it with the public.
I understand it's hard to change, but we should change it.
But you think we should use we should use single anastomosis?
I would say omega loop. Roux-en-Y, omega loop.
Yeah.
But that's my opinion. I know people don't like omega. Could be single anastomosis. It has to be a short name, something that's easy to remember, but we should get rid of the mini term.
But the problem with single anastomosis is that in abbreviation it's LOAGB, and that's what was used for the gastric.
Then use omega. Then use
there is a
omega.
need to organize a conference, a consensus conference about the names. So we. No, the next question. I would like to have your opinion about the metabolic syndrome and in the two procedures, which one is better, has better effects or worse effects. Who wants to begin?
Well, actually, we studied 4 years after the procedure. We studied 14 patients who had a mini bypass, single anastomosis bypass. 14 patients who had a Roux-en-Y gastric bypass, comparative groups, and 14 controlled that were also comparable. And we found that the submitted to an oral glucose tolerance test, there was no difference in terms of glucose, but there was a difference, but not significant in insulin production. So after a single anastomosis gastric bypass, there's more insulin being produced to maintain euglycemia than with the Roux-en-Y gastric bypass. So the cause is probably that in the Roux-en-Y there's no absorption whatsoever of glucose. So therefore there's less insulin needed to counteract that absorption of glucose.
Well, we studied the first 100 diabetes operated with the mini bypass, and after 2 years, the remission rate was 87 cases, so which is quite the same numbers as with the BPD. So it's important metabolic work of the mini bypass. That's sure. I just have to add that in France there is a prospective randomized trial comparing the Roux-en-Y to the mini bypass, which is going on and will be ended in 2018. All the patients have been included, and what we know until now from the first 100, which is quite amazing, is that the dumping syndrome is much more frequent in the Roux-en-Y than in the mini bypass. And there's differences in weight loss and so on, but there is much less dumping syndrome according to the Zigstad questionnaire with the mini bypass than with the Roux-en-Y, for example.
Yeah, but the dumping syndrome is thought by many to be a good thing after Roux-en-Y because it prevents patients from eating sweets or too much. So you can turn it either way. Can be good, can be bad.
It helps.
Yeah.
But when you talk about public perception of weight loss surgery, one of the big issues is the number of times patients get into problems and have more operations. The second one is that people have had the operation and lose the weight but gain the weight. And many patients, particularly in the United States where I practice, are very concerned about having a gastric bypass because they are afraid of the word dumping, which in the vernacular in English means going to the bathroom, having a bowel movement, and which is really not part of the classical dumping syndrome, which is, hyperhidrosis and tachycardia and cold sweats, and it doesn't necessarily involve that. So again, I'm not sure. I think the longer you bypass the intestine, the longer your limbs are, the more you're going to get a metabolic effect of this operation, what we used to call malabsorption, and now we should call metabolic effects. And this whole restrictive argument is sort of a lot of, because most patients with a gastric bypass actually eat more calories than controlled weight. So once they've lost the weight, they still eat more calories. So they're not really restricted in either of these operations once they get over the initial post-operative phase.
I think that to have a more powerful metabolic effect with the single anastomosis gastric bypass is pretty expected, because if you want to increase the metabolic effect of the Roux-en-Y gastric bypass, we distalize the procedure. So this is a Roux-en-Y with more distalization. But the other side of this situation is that we have more powerful metabolic effect, but we have more malnutrition also. So it's more common to have anemia, it's more common to have hypoproteinemia with this patient. So I think that we have to look for a balance in between these procedures and the correct indication for the patients.
Okay. You spoke about the necessity for supplementation. What's about the supplementation in both procedures? You need more supplementation in a single loop, or?
I think that the principal problem is following what has just been said. The principal concern with mini bypass is limb length, because the classical mini bypass is supposed to be 200 centimeter, and 200 centimeter bypass on a young woman which is 40 of BMI could be too much. That's why since 2 years we studied only 1 meter and 50, and well, there are cases of malnutrition, but always because the limb length has not been measured correctly, sometimes the bypass is 3 meter. So of course the problem of supplementation and vitamin is much higher if the bypass is too large. And there has been also publications saying that we must tailorize the bypass, but until 3 meter. And I don't agree at all with that. I think it could be dangerous. The malabsorption could be too much. And I think 1 meter 50 if the BMI is under 50 is okay, and 2 meter if the BMI is over 50 is enough, not more.
Can we go a little bit into how to measure? Because if measuring is important, what I've seen this morning is not very accurate measuring.
True.
Actually, we measure our bowel length using a tape that we run along the bowel, and that's probably not entirely precise, but it's certainly more precise than what we have seen this morning.
Absolutely. But may I raise a point though? I don't understand why the 200 centimeters of a mini bypass would induce more so-called malabsorption than what I've always seen being done in Roux-en-Y gastric bypass, which is a biliary limb of 50 and 150 elementary. So you bypass effectively 200 centimeters just as well. So why would there be more malabsorption with the mini bypass than with the Roux-en-Y gastric bypass with this construction?
It's because we don't measure the whole limb. The problem is we all suppose that the total limb length is 6 meter, or we all know that it can be from 3 meter to 10 meters. So it's so different. We should measure the whole limb length since the colon, but it has its own morbidity to measure this.
But why would this be an issue now with the mini bypass, whereas we've been doing that for years with the Roux-en-Y Gastric Bypass? 50,
Well,
but then 50.
So the more you open the book on malnutrition, it's a very complex issue because it's never really been studied very well. And the reason it isn't studied very well is because a lot of times we don't measure pre-existing malnutrition in patients that are morbidly obese. We assume because they're obese, they eat well. But we learned that many of them are vitamin D deficient, many of them have thiamine deficiency to start, and zinc deficiency, so you find a whole bunch. The second thing is we assume, because we tell them to take the vitamins and the mineral supplements, that they take them, but the only real studies you do is if you actually give them, just like you do in a study on medication utilization, you give them, and at the end of the month, they give you the ones back. And there's very few, if any, studies that have compared the controls. Anyone who's taken more than pills, 3 pills a day for a week understands how difficult it is to take 5 or 6 pills a day every day forever. So it's very, very complex. But I think Jacques' point is very accurate. The difference, perhaps, Jacques, is that first 100 centimeters of bowel is still able to absorb carbohydrates, but maybe not certain minerals or vitamins. So I'm not sure, the total amount that you actually bypass, and by bypass you assume that nutrients aren't in contact with acid or saliva and bile. And I think this is a really complex issue, and we're not going to solve it. But the more you make an operation malabsorptive, the more you change an operation or a pathology from diabetes and obesity to iron deficiency, anemia, osteoporosis, oxalosis, kidney disease from stones. You start to get into some serious issues. So the bottom line again is always in bariatric surgery, it's just the first step. Whether you do a gastric bypass, whether you do a mini gastric bypass, it's just the first step. And unless patients are routinely and well followed, and it depends on where they live, what their opinions of their doctors are, whether they move, what country they live in, et cetera, you're going to get into a lot of different conversations that have nothing to do with the operation, but have a lot to do with the patient.
So there's another very important question. What's about weight loss? Is that the same weight loss in both operations, or you have better results in one or in?
I think there's some evidence that there's more weight loss with the mini bypass, but again, what are we comparing? I mean, the single anastomosis. But what are we comparing? Are we comparing what limb lengths were used for the Roux-en-Y, what limb lengths were used for the mini bypass? So again, to go back to the study we did 4 years after the bypass procedures, they were constructed exactly the same, which means we bypassed 2 meters of bowel with the mini construction and 150 and 50 with the Roux-en-Y Gastric Bypass. And we saw that there was significantly better weight loss with the mini bypass than with the Roux-en-Y. After 4 years, we had a mean weight loss of 100% after 4 years with the mini bypass, and I think it was 78% with the Roux-en-Y Gastric Bypass, which was statistically significant, but in a small group.
So, Jacques, if you do all these comparisons, how long does it take to see a patient for weight loss surgery if you're offering them all these different options?
How do you mean?
Well, you have to go through a pretty long, detailed explanation if you're going to do a gastric bypass and why you're going to do a mini bypass or...
It's actually pretty simple because we have an algorithm. And the algorithm is based on contraindications, which means that, as I said, when you have reflux, it excludes you for mini bypass and for sleeve hysterectomy, so it indicates you for Roux-en-Y Gastric Bypass. If you don't have reflux, and for instance you have diabetes, type 2 diabetes, then you're an ideal subject for a single anastomosis gastric bypass, at least according to that algorithm. It's not an evidence-based algorithm, it's just an empirically established algorithm. But we've been using it and the patients have no trouble in accepting it.
What about in Brazil? Does anybody get a mini bypass?
No, there is no rule. Actually, this is not a approved procedure in Brazil. We use only in medical studies in order exactly to try to identify the correct patient to recommend the procedure, but it's not a standard procedure to use in Brazil or in Latin America.
Mike.
Just would like to mention one issue, and Jacques certainly is a very skillful surgeon and has a very good reputation in all types of bariatric procedure. But what we have seen in Belgium, I think that besides you, probably there are 2 or 3 other surgeons practicing the mini gastric bypass. I really think that the training of those guys, certainly has not been appropriate, because we had to do already quite a lot of undo of the mini gastric bypass because of that bireflux. And like some papers are mentioning 0.5%, I think Gansé is at least mentioning 5%. So a lot of surgeons really go too high on their gastric pouch. And you demonstrated very nicely, Jacques, but in reality, a lot of surgeons, don't have the skills to really go 13 centimeters from the gastroesophageal junction. And so they go somewhere between a regular gastric bypass and then the mini gastric bypass. Now that is really happening in clinical practice. So that's also reality. I mean, we had to do really already a lot of conversion to the Roux-en-Y because of that problem. And I know in other countries, because it's more feasible, so probably also a bit more, let's say, less skillful surgeon are going to make that step for a sleeve, going from a sleeve to a mini gastric bypass, because, they don't have the skills, or they do not think they have the skills to do a proper Roux-en-Y gastric bypass. That's the reality on field.
So when you go to a mini bypass from a sleeve, that has to be like incredibly ulcerogenic, because it's actually like a retained antrum. It's like the old ulcer surgery.
I was mentioning surgeons that were doing sleeve gastrectomies, and they say, now I'm going to try to do a more difficult step. Now I'm going to make a gastric bypass, like a lot of surgeons were just doing a band. We're very pleased that the sleeve was coming up. Then they go to the mini bypass. With all those problems, they are very keen, to make a pouch at 8 centimeters, 7 centimeters, and then leave a bit more at the fundus as well. Causing not only even bile reflux, but even acid reflux. It's not only bile reflux that we have seen on the mini gastric bypass, but also even acid reflux, which is more predominant, I think. And so what you mentioned as well, I think, Jacques, probably not like Jean-Marc Chevalier saying, is there really objective reflux endoscopically proven? This could really become a contraindication to do a mini gastric bypass. So on that part, I really do agree what Jacques just has mentioned. So
Bruno, it reminds me of what happened 20 years ago with the VBG. It's very difficult to standardize completely a surgery, and those who have been developing the sleeve gastrectomy told the same. Some sleeves were too large and the patient didn't lose weight, something were too narrow and the patient had leakages, because it was difficult to standardize. And I agree with you that I've seen so-called mini bypass all over the world that were not. The tube was too large, was too close to the G junction. So it's really very important to know exactly what we're talking about and to do all the same operation.
That's right.
But we don't really do that operation, to be honest, with any operation. So we saw 2 different gastric bypasses today, and we would, if everybody in this room who did a gastric bypass, some of them would look very similar to others, but the gastric bypass operation is certainly not standardized, and I appreciate Dr. Vic's doing the diagram, but some people make a longer, narrower pouch, some people make a shorter, fatter pouch, some people make their BP limbs 50, some people vary it according to BMI, some people make it 100 as a baseline. Some people, even the anastomosis and the anastomosis size, we saw all different kinds of anastomosis today. So standardizing an operation, but again, not every patient is standardized either. So there's body mass index of 50 where you go in and it's the easiest surgery, and then you have body mass index of 50 where you have a hiatus full of fat. So you know, we're not doing the same type of medicine. I think we do ourselves a disservice, though, as metabolic and bariatric surgeons, by trying to say one operation is going to be bigger than the other one, or I only do this one, or I think you need to have some kind of algorithm, and it would be good for us as a group, and not the group in this room, but as a group, to have an algorithm for certain surgeries, and then try perhaps to justify that algorithm with some kind of basis of data.
So I think we have to conclude. And the last question, I just want to summarize why you are doing Roux-en-Y gastric bypass, or why you prefer single limb anastomosis, just for summarizing, because there were a lot of arguments, and for the people that are coming.
Well, I'm evaluating the mini bypass, and it takes 10 years, so that's why we are doing mostly, but for the prospective randomized trial, we did also Roux-en-Y. So I'm going on because it's part of my mission.
Well, as I mentioned, I do both, and I have my indications for both. And as however say, when I run into trouble doing a mini bypass, when I think there might be an issue with the anastomosis, I know I can't stand that if there's a leak, then I don't hesitate, and I always do my informed consent in that way. I don't hesitate to do a Roux-en-Y gastric bypass rather than a mini bypass. But I think surgeons should be capable of doing both, single anastomosis and Roux-en-Y gastric bypass, and but it's probably a matter of indication.
Maybe for patients with BMI more than 45 or super obese, or for patients with more severe metabolic disease or diabetes, that we can recommend a single anastomosis gastric bypass. I think that is pretty clear that for patients with severe reflux, it's not a good procedure. For patients, for normal morbid obese patients, that we have very stabilized criteria with Roux-en-Y gastric bypass or sleeve gastrectomy, also this is not a good option.
I still will prefer in the near future also still the Roux-en-Y gastric bypass. Just I think indeed there could be some added value for high-risk patients, and certainly older patients. Older than 50 years old, high BMI, high-risk patients. I think there could be a player to start with the mini gastric bypass in our unit, but otherwise we certainly still will prefer the Roux-en-Y type.
Michel?
Well, I'm still sticking to the Roux-en-Y gastric bypass, and my main concern is bile reflux, mostly silent bile reflux, and its potential influence on esophagitis, Barrett's, and esophageal cancer. And that's something that's going to happen 20 years, 30 years down the road. We won't be around to witness it, but could be dramatic for the patients. We operate on relatively young patients, and that's my main concern. I may be completely wrong, but we have a good tool with the Roux-en-Y, and I see no reason to change.
That's a good point.
So, again, here comes me. Roux-en-Y gastric bypass, my preference, is time-tested, complications known, more than 50 years on the road. Mini gastric bypass have to do his own work. What's the homework? Clear the noise of the literature. And we face that with metabolic surgery. It's a natural step. Because what is the message we are giving for the scientific community? No, we have this procedure that's better than other. I don't think this is people don't understand, will not understand our message. So we clearly have to identify the space of each one of those if you wanted to progress in to be more accepted by the scientific community.
Okay. You want to conclude?
No. I think several really good points were made. I congratulate Dr. Chevalier, because I think if you do an operation for 10 years, you end up figuring out the good and the bad of the operation. If you compare the results and you follow the results, you'll answer many of these questions. And I think that if you stick with what you have only, you will never advance. But Manuel made a very, very good point, and you see that whenever you go to a metabolic meeting, because the people we're trying to convince in the beginning need to be not only the patients, but the general doctors or the internal doctors who see the patients with these metabolic syndromes. And we have not done ourselves a disservice because, you know, we had everything was going to be solved by the band and everything was going to be solved by the sleeve. And now if we start with everything is going to be solved by the mini gastric bypass, and we always come back to gastric bypass. So I think we need to prove to ourselves in studies like Dr. Chevalier's study that we will see and get some answers, and then we'll be able to tell our patients, according to the data, this would be the better way to go.
Okay, that was the final remark for that webinar. I was very happy for all the participants coming for hearing the faculty here, and hope we can do very soon a new webinar, and we can welcome you again. Thank you.
Thank you.
Bon.
Genre des parties prises.